mask since 10 years. Okay, so no one recognizes me, and half of the time I'll be in my blue scrubs only with a cap, so no one recognizes me. So what we do? So if you ask any student who has who knows about anesthesiologist or some school going students, what they say when they look at my work, they say like what we do is I stab people in the back with a sharp object when they are awake, or show a tube in the throat when they are not. So it's a very crude description of an anesthetist, right? So what we do are the things which for a normal person it looks like, sir, what are you doing on this patient? So actually nobody knows what we do until we don't do that. Actually, so anesthesiologists or doctors who keep patients alive while surgeons do the things that would otherwise kill them. This was the famous statement that was given. This is my picture where I'm anesthetizing a patient. So I'm also using the mask, but in a different fashion. We'll understand what is happening. So before beginning into this lecture, so what is anesthesia? First understand what is anesthesia. So as we all know, anesthesia means loss of sensation. Loss of sensation. There are so many sensations in our body, like touch, pressure, tickle. So many sensations are there. Which sensation is lost? So very important for me is loss of pain sensation. Sir, why pain? Is pain good or bad? The second question that comes into the mind is pain good or bad? Obviously, pain is a good sensation. Why, sir? Because of the pain only, the patient is coming to me and meet a doctor. Suppose if you are not having pain, what will you do? You watch the TV and you apply some non-medical things. Suppose if you are having a small rash, what will you do? Immediately you go to your kitchen, you get some haldi and you keep it on the hands. Nothing, sir, I want to become fat. So unless you have a pain, you don't come and meet a doctor. So obviously pain is a one good reason why my pockets are filling. But what is the other reason? So pain is very important stimulus for our survival. Why? Imagine a situation. I am walking on a road. Suddenly my leg got twisted. So what will happen? What do you mean by leg got twisted? That means I got some ligamental injury. Suppose if I am having a pain, I will go to home and I will rest. Suppose if I am not having a pain, what will I do? I continue to walk. If I go on walking, what will happen? The ligamental injury which was there on my leg, it will get aggravated. At one point of time, the ligaments will give off. The moment ligaments will give off, what will happen? The bone joints will get subluxated or they get dislocated, they get necrosed, and finally they will chop off my leg because whole of the thing will become not useful for me. Right? So pain is one important stimulus. That is, pain is obviously good stimulus. Because of this only we are surviving. We are surviving because of this pain stimulus only. Now coming back to the previous definition, what is anesthesia? Anesthesia is loss of pain sensation. So is pain good or bad? So obviously you have accepted the fact that the pain is a good sensation. Now if it is a good sensation, and as an anesthetist, if I am taking out your good sensation, what is left over? So in the world there are only two things. One is good and another one is bad. So if I am taking out good sensations from your body, what is left over? So obviously you might be thinking that I'm a bad anesthetist. Obviously in front of many of my surgeons, they feel that anesthetists are bad people. Right? We obviously do good things. How, sir? How it is logically correct? You are taking out good sensation, but again you are saying that you are doing good. How is it possible? I'll tell you the reason. Suppose again, imagine one more situation. You are walking on a road. Suddenly someone comes and gives you a tight slap from the back. What is your response? Will you be like, come, beat me, go? Or will you say, who is this who has beaten me? So obviously you will have the second option. Who is this? So when you have a pain stimulus in your body, what kind of hormones are released in your body? So obviously whenever you have pain stimulus in your body, pain is going to release. Pain releases. What does it release? It releases sympathomimitic hormones. Sympathomimic hormones. What are the examples of sympathomimic hormones? It's very clearly, you all know, adrenaline, noradrenaline. Very good. So what will happen if the pain is causing release of sympathomimic hormones? What are these hormones are called? In our school days we have learned it. These are the hormones of fight, flight and fright. So obviously you will have an increase in heart rate. Right? With this hormone there will be an increase in heart rate. With this hormone you will have an increase in blood pressure. With this hormone you will have an increase in cardiac output. With this hormone you will have an increase in respiratory rate. With this hormone you are having an increase in liver blood flow, renal blood flow, muscle blood flow. Everything is increased. That means you are preparing for fight, flight or fright. So if you are charged up to take the action, that means your body is prepared to do more amount of work. Obviously you are doing more amount of work. So if you are doing more amount of work with the release of sympathetic hormones, there will be increased workload on your body. If there is so much amount of workload on your body, but think a situation where your body cannot take that load. Suddenly someone comes and says, tomorrow is your next examination. What will you do? What will you do? You will take all 19 subjects textbook in front of your table and start reading it? No, obviously you will not do it. So you close all the subjects and you will go for a movie. Right? In the same way, so there is so much amount of enormous increase in the workload on your body, but your body cannot do it. What will happen? Eventually, if your body cannot take this workload, it will lead to fail. What do you mean by failing here? So here the failing means the patient will present in the post-operative period or intraoperative period with a cerebrovascular accident or a coronary artery disease in the form of myocardial ischemia or So there is so much amount of enormous increase in the workload on your body, but your body cannot do it. What will happen? Eventually, if your body cannot take this workload, it will lead to fail. What do you mean by failing here? So here the failing means the patient will present in the post-operative period or intraoperative period with a cerebrovascular accident. Or a coronary artery disease in the form of myocardial ischemia or infarction, or patient will have post-operative renal failure, what not, all the complications that you can think of it that can be happening in the post-operative period just because we are not taking care of pain sensation. So you might have heard this statement that operation is success but the patient is died. How this came into the picture? So this came into the picture because in previous days, before the advent of anesthesia, people used to just operate without taking care of this good sensation. So once this good sensation, pain is taken care of, that means you will have a good outcome in the post-operative surgery. So that's the reason why if you look at the figures in 18th century, 19th century, surgery, they have a huge mortality and morbidity in the post-operative period. But nowadays we are not having this, just because we are able to take care of the very good sensation that is pain. So even though I am removing your pain sensation, I am doing good to your body. How I am doing good to you? Because I am taking care of this increased workload that your heart cannot take by giving anesthesia. So even though I am taking good sensation from your body, what is left over? There is a good sensation that is left over in your body. So I am a good anesthetist. We are good people only because we are taking out pain sensation, but still we are doing good to the body, right? So what are the sequence of events that happen when a patient is coming into the operation theater? If you are an intern, if you have worked in your department of surgery, you know this sequence. Just I'll quickly review it so that you will not forget it. Suppose it can be a surgical case, which can be an elective surgery, or it can be an emergency surgery, right? It can be an elective surgery or it can be an emergency surgery. So whatever might be the case, the first thing what I need to do is I need to do the pre-anesthesia checkup. I need to do the pre-anesthesia checkup for the patient before coming the patient. What is the main purpose of pre-anesthesia checkup? Is to identify what are the problems that the patient is having. So once the patient problem is identified, suppose if he is not having any problem, then I will say he is provisionally fit. I will say he is provisionally fit for surgery, or if he is having a problem, I will try to optimize the patient condition in the given situation. I'll try to make him fit for surgery. There is nothing like unfit. Unfortunately, in our medical colleges, we are taught like unfit. But I will try to make him fit for getting operated in the given time. If it's an emergency, whatever the time period that is available, I'll try to make him fit. If it's an elective surgery, whatever the time I can buy the time in the elective surgery. Right? So once I optimize the patient general condition, I will give him on advice on pre-medications, or I will tell him what medications he will use or what he should be stopped, and I will tell him what medications he should use. So these are also called as pre-medication drugs. Then we will proceed for surgery. Obviously, we will proceed for surgery. From here, you will be entering as an intern into the operation theater. So once the surgeon has given your surgical incision, from here only you will start. So before that, whole of these scenarios will happen. Pre-anesthesia checkup, optimization, making him fit for surgery, and then we will proceed for surgery. From there, the patient will be taken into the post-operative. This is on it's a bird's view. Superficially, this is what happens, and you all know it. No one will ask you, right? So the next question that comes is, how many kinds of anesthesia are there? So if you ask me how many kinds of anesthesia, many students, or how many types, I'll put it as not kinds, I'll put it as types of anesthesia. So how many types of anesthesia are there? Many students think that anesthesia, there are 3 types, general anesthesia, spinal anesthesia, epidural anesthesia, Ramakrishna Chaitanya lectures. No, not lectures, right? So anesthesia is basically divided into 3 categories, right? One is general anesthesia, the second one is regional anesthesia, the third one is monitored anesthesia care. General anesthesia, regional anesthesia, and monitored anesthesia care. So I'll quickly tell you what happens in a general anesthesia, because as I said you, many students don't see what an anesthetist is doing. They are more interested in what surgeon is cutting. Unfortunately, examiner knows exactly what you don't know, and he will give you a simple question there, and many students, they fumble over there. That's the whole purpose of an examiner, right? So he wants to ask you what you don't know. So I'll give you, if you know it, just you can skip this part, or else you just try to listen it. So what happens in general anesthesia? So in general anesthesia, the first thing, whenever a patient comes into my operation theater, what I do is, first thing, I will put all monitors to the patient. I will attach all monitors to the patient. We'll talk about these monitors later, right? Then what I will do is, I will keep an IV And this is very important. All these areas are very important for your entrance examination. What are the sizes of an IV cannula that has been asked many times. Okay, then once monitors are attached, once I keep the IV line, what I do in general anesthesia is the first thing I will do is I will give induction agents. What do you mean by induction agent? Induction, it's an English term, it's not a medical term. Induction means to start. What are we starting? We are starting general anesthesia. So to start general anesthesia, general means whole of your body will get anesthetized. So if I want to induce induction agent, that means I'm going to put you to sleep. Induction agents, these agents, they put patient into sleep. They put patient into sleep. So how do we classify these induction agents? So these induction agents, they are classified into two categories. One is intravenous induction agents. The second one is inhalational induction agents. Inhalational induction agents. So what are the examples of intravenous induction agents? The examples are thiopentone sodium. We'll talk about all these things later. Just remember or write down in your notes. Thiopentone sodium, propofol, etomidate, and ketamine. Why I am telling you? So that you will get acquainted with these words, right? So we call it as induction agents. Induction agents, they put you to sleep. There are another group of induction agents. They are called as inhalational induction agents. The examples are halothane, isoflurane, sevoflurane, desflurane. Halothane, isoflurane, sevoflurane, desflurane. So in this only we have ether and chloroform. They are older agents. Nowadays we are not using these agents. So when I administer these agents, what will happen? So these agents, they put you to sleep. Now here comes a very important thing you need to understand. So if pain is a stimulant in your body, what are all my anesthetic agents? Most of my anesthetic agents, they are depressants. Most of my anesthetic, there are some exceptions. When we are talking about pharmacology, you will understand. Most of my anesthetic agents, they are depressants. So what do they do to your heart rate? Obviously, pain is increasing your heart rate. Anesthetic agents, they decrease your heart rate. Pain is increasing your blood pressure. Anesthetic agents will decrease your blood pressure. Pain is increasing your intracranial pressure. Anesthetic agents will try to reduce your intracranial pressure. Pain is causing respiratory stimulus. Anesthesia is reducing the respiratory stimulus. So here comes a big problem. So what happens is when I give these induction agents, all these agents, they are depressants and they try to reduce your respiratory rate. Here comes a very big problem. If the respiratory rate is reduced, you will go into apnea. Obviously, you will go into apnea and you will have hypoxia and your brain will suffer from complete hypoxic brain damage. If you give three categories, right? One is general anesthesia, the second one is regional anesthesia, the third one is monitored anesthesia care. General anesthesia, regional anesthesia, and monitored anesthesia care. So I'll quickly tell you what happens in a general anesthesia, because as I said you, many students don't see what an anesthetist is doing. They are more interested in what surgeon is cutting. Unfortunately, examiner knows exactly what you don't know, and he will give you a simple question there, and many students, they fumble over that. That's the whole purpose of an examiner, right? So he wants to ask you what you don't know. So I give you, if you know it, just you can skip this part, or else you just try to listen it. So what happens in general anesthesia? So in general anesthesia, the first thing, whenever a patient comes into my operation theater, what I do is, first thing, I will put all monitors to the patient. I will attach all monitors to the patient. We'll talk about these monitors later, right? Then what I will do is, I will keep an IV cannula for a patient. And this is very important. All these areas are very important for your entrance examination. What are the sizes of an IV cannula that has been asked many times. Okay. Then once monitors are attached, once I keep the IV line, what I do in general anesthesia is, the first thing I will do is, I will give induction agents. What do you mean by induction agent? Induction, it's an English term. It's not a medical term. Induction means to start. What are we starting? We are starting general anesthesia. So to start general anesthesia, general means whole of your body will get anesthetized. So if I want to induce induction agent, that means I'm going to put you to sleep. Induction agents, these agents, they put patient into sleep. So how do we classify these induction agents? So So these induction agents, they are classified into two categories. One is intravenous induction agents. The second one is inhalational induction agents. Inhalational induction agents. So what are the examples of intravenous induction agents? The examples are thiopentone sodium. We'll talk about all these things later. Just remember or write down in your notes. Thiopentone sodium, propofol, etomidate, and ketamine. Why I am telling you? So that you will get acquainted with these words. Right? So we call it as induction agents. Induction agents, they put you to sleep. There are another group of induction agents that are called as inhalational induction agents. The examples are halothane, isoflurane, sevoflurane, desflurane. Halothane, isoflurane, sevoflurane, desflurane. So in this only we have ether and chloroform. They are older agents. Nowadays we are not using these agents. So when I administer these agents, what will happen? So these agents, they put you to sleep. Now here comes a very important thing you need to understand. So if pain is a stimulant in your body, what are all my anesthetic agents? Most of my anesthetic agents, they are depressants. Most of my anesthetic, there are some exceptions. When we are talking about pharmacology, you will understand. Most of my anesthetic agents, they are depressants. So what do they do to your heart rate? Obviously, pain is increasing your heart rate. Anesthetic agents, they decrease your heart rate. Pain is increasing your blood pressure. Anesthetic agents will decrease your blood pressure. Pain is increasing your intracranial pressure. Anesthetic agents will try to reduce your intracranial pressure. Pain is causing respiratory stimulus. Pain is, in anesthesia, is reducing the respiratory stimulus. So here comes a big problem. So what happens is when I give these induction agents, all these agents, they are depressants and they try to reduce your respiratory rate. Here comes a very big problem. If the respiratory rate is reduced, you will go into apnea. Obviously, you will go into apnea and you will have hypoxia and your brain will suffer from complete hypoxic brain damage. If you give these agents in your ward or without a person who can take care of the airway, then obviously you are killing that patient. A very, very dangerous drug these group of drugs are. So what we do is immediately we know as an anesthetist or a medical student, we know that there is something called as airway management. What do we do? Airway management. What do you mean by airway management? Many people, they traditionally think that airway management is putting an endotracheal tube inside. There are but as air care, you will go into anesthetic agents will decrease your temperature. Pain, you need to understand. So if this the inhalational induction agents, the examples are halothane, isoflurane, sevoflurane, desflurane. Halothane, isoflurane, sevoflurane, desflurane. So in this only we have ether and chloroform. They are older agents. Nowadays we are not using these agents. So when I administer these agents, what will happen? So these agents, they put you to sleep. Now here comes a very important thing you need to understand. So if pain is a stimulant in your body, what are all my anesthetic agents? Most of my anesthetic agents, they are depressants. Most of my anesthetic, there are some exceptions. When we are talking about pharmacology, you will understand. Most of my anesthetic agents, they are depressants. So what do they do to your heart rate? Obviously, pain is increasing your heart rate. Anesthetic agents, they decrease your heart rate. Pain is increasing your blood pressure. Anesthetic agents will decrease your blood pressure. Pain is increasing your intracranial pressure. Anesthetic agents will try to reduce your intracranial pressure. Pain is causing respiratory stimulus. Pain is in anesthesia is reducing the respiratory stimulus. So here comes a big problem. So what happens is when I give these induction agents, all these agents, they are depressants and they try to reduce your respiratory rate. Here comes a very big problem. If the respiratory rate is reduced, you will take care of the airway, then obviously you are killing that patient. A very, very dangerous drug these group of drugs are. So what we do is immediately we know as an anesthetist or a medical student, we know that there is something called as airway management. What do we do? Airway management. What do you mean by airway management? Many people, they traditionally think that airway management is putting an endotracheal tube inside. There are other ways also. Yes, endotracheal tube is one part of airway management. Airway management means giving oxygen in, taking out of carbon dioxide out. Not only giving oxygen in, but also I have to make sure that the carbon dioxide is also venting out from your body properly. For that, we use endotracheal tube, laryngeal mask airway. We'll talk about this endotracheal tube, laryngeal mask airway in the section of airway management. But what happens in practical situation is after giving these induction agents, and if I want to secure the endotracheal tube for the patient, unfortunately, the patient will have a gag reflex. The patient will not allow me to put the endotracheal tube into your body. Why? Because the gag reflex, what the patient is having, is a brainstem reflex. Which will not go. That is the last reflex that goes from your body. If you are not having gag reflex, then I will categorize you as a brain dead patient. So unless this gag reflex is gone, otherwise what will happen? You try to put the endotracheal tube, the patient is having gag reflex. So obviously again the heart rate is increases, the blood pressure increases, the ICP increases with the gagging. So everything again going back to the scope. So what we do is, in order to facilitate the airway management, we use one more group of agents that is called as muscle relaxants. Muscle relaxants. What is the purpose of muscle relaxants? Now you understand it better. The purpose of muscle relaxants is to facilitate airway management from anesthesia point of view. From surgical point of view, they will give them adequate time for exposing the structures. If the muscles are relaxed, then the surgeon can do nice dissection, right? So the purpose is not of muscle relaxant is to provide, from an anesthetist point of view, is to facilitate intubation or airway management. So how do we classify muscle relaxants? Again, in your pharmacology, it has been given that the muscle relaxants are basically classified into depolarizing muscle relaxant and non-depolarizing muscle relaxants. I will write it as NDMR. So what are the examples of depolarizing muscle relaxant? Succinylcholine. We all know it in your pharmacology. Second year in pharmacology, KD Tripathi textbook or Katzan textbook, we have read this one. In non-depolarizing muscle relaxant, we have pancuronium, vecuronium, atracuronium. All these drugs we talk about when we are talking about the pharmacology of the drug. So if I give muscle relaxants, immediately the patient will allow me to put the endotracheal tube inside. And once the endotracheal tube is kept inside, I connect it to the oxygen source. Again, what I will do? From here, the surgeon will come and he will start giving incision on the patient body. From here, as an intern, many interns come into the operation theatre, and from here they will look at what the surgeon is doing. They are more interested in looking what the surgeon is cutting. Because from here, my job will be like this. I'll be sitting calmly and I will be looking at what? I will be looking at the monitor. I will not sleep or I will not use the WhatsApp. I will be looking at the monitor. The whole of my job is monitoring only. So you can understand what is the why I have attached the monitors in the beginning. So your favorite surgeon came and he has doing surgery, and whole day I will be sitting at one corner and I will be watching you like this. What all my interns are doing, what is my patient doing, what is the surgeon doing. So whole day I will be looking at the monitor till the surgery is over. So once surgery is over, what will you do? Immediately what you will do as an intern, immediately you change from your scrubs and go to canteen. But I will not go there. So what I have to do is I have to take the patient out of anesthesia. Now the whole point is the patient muscles are relaxed. So at the end of surgery, what I will do is I will give him reversal. So that the effect of muscle relaxant is reversed. So what is the drug that we give when as a reversal is we use neostigmine. So understand, I am reversing the effect of muscle relaxant. I use a drug called neostigmine. What is this neostigmine, sir? Somewhere in second year pharmacology I read, sir. Neostigmine is acetylcholine esterase inhibitor. We'll talk about these drugs. You might have heard it in pharmacology. I'll just superficially tell you what is this reversal. Right? So once I give this reversal, what will happen is the patient muscles, whatever that were relaxed, it will come back to the normal tone. The moment the patient muscles come back to the normal tone, what will I do? Immediately, the patient will not keep the endotracheal tube or LMA in his body, and I need to extubate the patient. What I will do? I will extubate the patient. Sir, surgery over, anesthesia is also over. What should I do? Immediately, I will change to scrubs and I will go to canteen and I have some chai samosa. No. Again, I need to shift the patients into the post-operative ward. Shifting is also my responsibility. So once I shift the patient into the post-operative ward, what will you do? Again, take out your mobile and look at your WhatsApp or post it on Facebook or Instagram. Hashtag first surgery. No. Immediately, again in the post-operative period, I will monitor. Sir, what are we monitoring exactly? So before knowing what are we monitoring exactly, know the areas where an examiner is interested. The examiner is interested in the pre-anesthetic checkup, what we have done before taking the patient in case. The examiner, this is one area which is very important for your entrance examination. Right? This is one more area, monitoring of the patient, because this monitoring is there in pre-operative period, intraoperative period, and post-operative period. Right? The third area is very much interested in an examiner is airway management. How are you? Because this is one source which will make you to make the patient survive even in emergency situations. Right? The other thing which an examiner is interested is knowing about these drugs, what we are using. Induction agents, reversal agents, muscle relaxants. See, so many MCQs are there. Again, this is a bird's view. Superficially, I am telling what an anesthetist is doing in general anesthesia. This is what we call as conduit of general anesthesia. How are we conducting a general anesthesia in a patient? So these are the areas which an examiner is really interested in it. Right? So what are we monitoring? So coming back to the slide, what are we monitoring? Monitoring of the vital parameters. The vital parameters, what are they included? They include your heart rate, they include your blood pressure, they include your respiratory rate, heart rate, blood pressure, respiratory rate, SpO2, EtCO2. What are these? We'll talk about this monitoring section when we monitor the temperature. Also, I monitor the fluid management of the patient during the surgery. This is that's the reason why I have understood, because when I was a postgraduate, I used to run from anesthesia department to casualty to take care of emergency medicine. I used to run from anesthesia operation theatre into the ICU area. Why? We were extending our branches like this. But nowadays, we have a separate department that is called as emergency medicine. We have a separate department that is called as critical care medicine. And most of the time, these are headed by anesthesiologists only. So, and these are very important areas for not only practical purposes, but also these are very important for your entrance examination. Because we are trained to monitor the patient. We are trained to know what are the fluid management that the patient should receive. We are trained to check the blood loss, whether the patient is having adequate amount of blood volume or not. If he is losing the blood, what should we do immediately? Right? And we will also, under anesthesia, we will look at the patient position so that he don't have any nerve compression injuries. Right? So that's the reason why we extended our branches. That's the reason why anesthetists will be considered as the one person who the whole hospital will look upon whenever there is an emergency, because I am trained to handle the airway. I am trained to give what kind of fluids. I know what to do in case of severe blood loss. And especially I can do all these things what an emergency physician. So from there, these branches, they have been, they have been segregated from anesthesia so that my job will become easier. Otherwise, every day I will be running here and there. Right? So this is very important aspect, and these are all very important for your entrance examination also. Types of fluids, what we are using, how much amount of blood, how much amount of, when to use an FFP, when to use a PRP, etc. So every day in my day-to-day job, this is what is happening when I am giving general anesthesia. Right? So this is the first part of the story, that is general anesthesia. What is the second part of the story? So one kind of anesthesia you understand thoroughly, that is general anesthesia. What is the second kind? I said you regional anesthesia. Sir, I know spinal, I know epidural. What is regional anesthesia? Again, I'll tell you. So when a patient patient comes into the operation theater, immediately I attach the monitors, there is no change here. From there, I keep an IV line, again there is no change here. If I am conducting regional anesthesia, what do you mean by regional anesthesia? So regional anesthesia is divided into two categories. The first one is central neuraxial blockade. Central neuraxial blockade. What is the other one? The other one is peripheral neuraxial blockade. I am writing it as P and B so that because I am a lazy person slightly, right? What do you mean by central neuraxial blockade? What is center of your body? Don't say your heart or my heart is with the girlfriend or boyfriend. No, center is your spine. So from your spine there are some nerves that are coming out, and from there I am giving the block. That is central neuraxial blockade. So what are the examples of central neuraxial blockade? The examples are spinal anesthesia. We'll talk about this: spinal anesthesia, epidural anesthesia, epidural anesthesia. The other one which you don't know, which I will tell you in the future sessions, that is caudal anesthesia. Spinal anesthesia, epidural anesthesia, caudal anesthesia. In these areas, what I will do is I will take a needle. And I will put it very close to your nerves, and I will inject local anesthetics. I have written LA for you, local anesthetics, so that that area will be blocked. Whatever the area that is supplied by that nerves will be blocked. So central neuraxial blockade. So coming to peripheral neuraxial blockade. In peripheral neuraxial, what is periphery to your body? Your limbs, upper limb, lower limb, head. So these are periphery to your body. So these have their own nerve supply. For example, for your upper limb you have brachial plexus. For your lower limb you have femoral nerve, sciatic nerve. For your thorax you have intercostal nerve. Right? So wherever there is a nerve, I can put a needle very close to it, not into it. I will put a needle very close to it and I inject a local anesthetic. So whatever the area that the nerve is supplying, that can be blocked. Right? So in peripheral neuraxial blockade, what are the example? I can give an example of brachial plexus block, femoral nerve block, intercostal nerve block, wherever there is a intercostal nerve block. Example. So wherever there is a nerve, we'll be going there and we'll put the needle. So what is the purpose of giving regional anesthesia? The purpose is very simple. It will provide anesthesia and also it can be extended into the post-operative period to provide analgesia also. If I can provide analgesia, I am taking out the bad effects of the pain. That's how I am managing a case. So in this, what are the examination important points? The examination important points for your entrance examination is central neuraxial blockade, because day in and day out I do this spinal anesthesia very importantly. Not only spinal, epidural and caudal also very important for your entrance examination. Coming to it, no one will ask you how are you doing this spinal. I will inject local anesthetics. I have written LA for you, local anesthetics, so that that area will be blocked. Whatever the area that is supplied by that nerves will be blocked. So central neuraxial blockade. So coming to peripheral neuraxial blockade. In peripheral neuraxial, what is periphery to your body? Your limbs, upper limb, lower limb, head. So these are periphery to your body. So these have their own nerve supply. For example, for your upper limb you have brachial plexus. For your lower limb you have femoral nerve, sciatic nerve. For your thorax you have intercostal nerve. Right? So wherever there is a nerve, I can put a needle very close to it, not into it. I will put a needle very close to it and I inject a local anesthetic. So whatever the area that the nerve is supplying, that can be blocked. Right? So in peripheral neuraxial blockade, what are the example? I can give an example of brachial plexus block, femoral nerve block, intercostal nerve block, wherever there is a nerve, intercostal nerve block. Example. So wherever there is a nerve, we'll be going there and we'll put the needle. So what is the purpose of giving regional anesthesia? The purpose is very simple. It will provide anesthesia and also it can be extended into the post-operative period to provide analgesia also. If I can provide analgesia, procedures. So what will happen, the patient came for MRI, the patient went into hypoxic arrest. So this is a very, very grateful situation. And one more reason is, if you use the word sedate, they will pay me only 500 rupees. If I use monitored anesthesia care, they might think, this person is doing something, and they will pay me 2000 rupees. So obviously there is a difference, right? So we don't use this word sedation because sedation is a very crude term. In monitored anesthesia care, I can monitor the patient when you are giving. I will also use the same drugs. But what is the difference? I am there to monitor your heart rate, blood pressure, respiratory rate. And I am there to, if there is something going wrong, I am there to put the airway management. And I am going to give the care. So what do you mean by MAC? MAC is used for small diagnostic and therapeutic procedures like MRI, radiotherapy, small surgeries like MTP, etc. There are so many small surgeries, so whatever that might be, small, it can be a small surgery, but anesthesia wise, there is no small anesthesia. We give monitored anesthesia care. I know how to look at the monitors. I know what if the monitor is going wrong, I will not panic there, and I know how to provide care to the patient. So this is monitored anesthesia care. So basically what we are going to do is, these are the three kinds of anesthesia. So if someone asks you how many kinds of anesthesia, don't say Dr. Ramakrishna Chaitanya's lectures. So anesthesia is basically divided into three categories: general anesthesia, regional anesthesia, the other one is monitored anesthesia care. And we all know what is the significance of monitoring. Already we have discussed. So this is about, in brief, overview of anesthesia introduction. Now let us go into the historical aspects. Why history is important? I don't know whether you like history or not, but I like history very much. What is the significance? You even have a channel, history channel. What is the significance of history? It's not for the purpose of fighting whether this is good or bad, but the purpose of history is to know what are the mistakes that your seniors have committed, or how the branch has evolved, so that you can speculate or think what can happen to that branch in the future. So this gives you a sequence of events. Previously, before 2015, there was no anesthesia question paper. I'll tell you, no anesthesia question paper without touching this topic of history. But of late, since 2015, I have not seen any question on historical aspect. I don't know the exact reason, but might be, one reason is, of late we are having more important things to be asked, but which doesn't mean that we should forget our history. History is very, very important. So what I did is, I am giving you a tabular column so that you can understand it. But what, sir, I don't remember history, sir. From school days, I am very poor at history. What I will do is, for each and every history, there is history. You can Google it, but what are the important things, I'll tell you, so that you will understand. And it will give you a very good image of history also. So what is this history? What does it include? So the first historical aspect is by Oliver Wendell Holmes. He's a great person who has coined the term anesthesia. So whatever the term what we are using, while writing a letter, he has written that instead of loss of pain sensation, he has coined the term anesthesia. You can remember that. Then comes Joseph Priestley. He is a very important person who has discovered, not invented, who has discovered what is oxygen, what is carbon dioxide or nitrous oxide, what we are using. So very important is Joseph Priestley, who has discovered oxygen. Okay, fine. These are very important. Then comes to anesthesia. Is very, very important. The first pioneer of anesthesia was this person. His name is Horace Wells. What did he do? Horace Wells is actually, just try to listen it. Don't try to stay in your brain. It's like a story. Horace Wells is actually a dental surgeon. So what he did, did you any time had a dental pain? Yes, obviously, dental pain is considered as the worst pain, because throughout the night you will be sitting in your hand, you're keeping your hand on the chin, and throughout the night you will be waking awake. And the pain is so bothering. Why? Because the dental pathology, it directly irritates your nerves. So that's the worst kind of pain that a patient can experience. So in previous days, whenever there was a pain, what the dental surgeons they generally do? They just remove that tooth. So in good old days, when there was no anesthesia, they used to remove the tooth, and while removing the tooth, they used to injure the nerve, and whenever you touch any nerve, it will cause intense amount of pain. As already I said you, pain causes release of sympathogenic hormones. So people, when they are scheduled for dental extraction, they were sitting on the bed, dental chair, and you try to remove that tooth without giving anesthesia, they used to injure the nerve, lot of sympathogenic hormones are released, leading to ventricular arrhythmias, and patients have collapsed. Now imagine a situation, you get a dental pain before advent of anesthesia, you go to dentist, he is trying to extract your teeth and you will never go back to your home again. Do you think the practice will flourish? No. Obviously, Horace Wells was also not having a very good practice in those days because, at that time they were not able to tackle the pain. So later, once he went for a party, one of his students, junior students, they called him for a farewell party. So in that party, many of you students also went to a farewell party. Many people will gather. Some people will be eating, some people will be drinking. In the same party, Horace Wells also had the same party. So all are eating, drinking, getting selfies. Now in those days there were no selfies, right? So they were having all these things. One group of students were going to one corner. They were inhaling some gas and they are getting euphoric. So in that party, one of his junior, he was jumping. After inhaling the gas, he was dancing on the dance floor. Suddenly, he fell down from the floor and he has got a broken tibia. Everyone gathered and asked, how are you feeling? He was like, I'm fine. So after 5 minutes, he was shouting and crying with pain. So one point that made this observation, that made Horace Wells great was, he observed that the patient didn't felt pain. So he thought that this is that gas. What was that gas? Which was they were taking and they were having that euphoric effect, which was causing laughing effect. So you can remember Horace Wells, what he has done is he has used this nitrous oxide and he has used it for the first time to remove the tooth extraction. And it was wonderful. It was wonderful for the patients. And immediately what he has done is he has given a public statement saying that Horace Wells, I will remove your teeth without causing pain. He gave a public demonstration. Unfortunately, on that public demonstration, what happened? He was a dentist, so he was trying to remove the tooth of the patient by giving nitrous oxide. Unfortunately, for the first 30 minutes, everything was going fine. At the end of surgery, the patient winced with pain. Oh, everyone in this room, on that day, they were they wanted to identify the flaws of Horace Wells. Unfortunately, this is our society, where people are not looking at the good point, but they are looking at the bad point. So what they have done, they bullied him so much, that at the age of 23, he committed suicide. Oh, very sad, very bright child. You can imagine. So what happened was Horace Wells was one person who has used nitrous oxide. First time he has used nitrous oxide, or first demonstration of anesthesia. Which was unsuccessful. Very important. Who gave first demonstration is Horace Wells. But in that group of people who were sitting there and watching this Horace Wells experiment, there was one more person by name W.T.G. Morton. He is an intelligent guy. What did he notice? That the patient didn't complain pain for 30 minutes. Around the beginning of the surgery, there was no pain. So what he did was, he went to his lab, he started experimenting with various other agents. He found out that there was one more agent by name ether. And it is very, very good agent. So what he did was, he also gave a very good first successful public demonstration by using ether. On which day? On 16th October 1846. So from this day, the branch of anesthesia came into existence. From this day, the branch of anesthesia, after his famous demonstration and in the Boston, he has said, gentlemen, this is not a humbug. He said, this is science, this is not a magic. I can remove the pain so that I can remove the painful or the bad effects of the pain. So from this day, the branch of anesthesia has started. Then came a very important person in the history, that is John. There were so many people. Then again, people started experimenting with various other agents. After a few days, after ether introduction, chloroform has become very, very popular. People started using chloroform also. But when it really became popular was this person by name Jon Snow. Who is Jon Snow? Don't think of your web series of Game of Thrones. Okay, he is not that Jon Snow. This Jon Snow is there in your SPM, PSM textbook. He is also known as father of epidemiology. What did he do? He has identified, if I am not wrong, in your SPM, he has identified the first cholera pandemic, or epidemic, sorry, not pandemic, first cholera epidemic in London city, right? Long back, you have read it when you were small kids in 3rd year, right? So the same Jon Snow, what he has done is, his professor was a person who was very fond of chloroform, and he was using chloroform. So one fine day, what happened, the Queen Victoria of London, she was having severe pains during her 8th time delivery, she was having severe pains. At that time, Jon Snow went and he has administered, very important MCQ, administered chloroform, CHCl3, I will write chloroform for Queen Victoria. From that time, chloroform has become popular, and from that time, obstetric anesthesia has also become popular. After her 8th delivery, she had 14 deliveries, it seems. The next 6 deliveries are with chloroform only. So you can imagine how good was chloroform. So people were very fond of anesthesia. People started using ether, chloroform, very popular. So here comes the first controversy. It's not a controversy, but people have created this controversy. So there came that controversy, that is, who is father of anesthesia? Is it W.T.G. Morton or Jon Snow? Sir, you told us a story where Morton has given public demonstration. Yes. Actually, what happened, this controversy came because we have two groups of strong people in our world, that is US people and UK people. So in US people, what they have done is, this Morton, he belongs to some Boston University, I don't know where he exactly belongs to. They really believe that the Morton was the first person who gave public demonstration. He is not an anesthetist by himself, but he has used ether as an anesthetic and he has provided anesthesia. So there is a very big statue of Morton in Boston University saying that he is one person who has removed the pain. But UK people, they never allow this use, they never accept this US person. So what they have said is, this Jon Snow, who has popularized chloroform, he has got his first MD anesthesia degree. And he should be considered as father of anesthesia. So people started fighting who is father of anesthesia. Some people say W.T.G. Morton, some people say John Snow, but who is father of anesthesia? There is no father in the standard textbook of anesthesia. What we follow or what examiners follow is the Miller anesthesia textbook. There is nowhere it has been written that he is our father, he is our mother, she is our mother, he is our brother. Nowhere there is written. So people created this controversy actually. Like what is happening in our society, people is creating this controversy. So, but sir, there were some questions who asked who is father of anesthesia, what should we mark? So immediately, because we were ruled by 200 years by Britishers, you go with John Snow. This would be a reasonably better answer, because most of our curriculum we have been adopted, even though we fantasize or we think about US, America, but we are ruled by Britishers. So just go with John Snow. This is a better option, because most of our professors, they still believe that John Snow is father of anesthesia. There is a controversy that is going on, but I don't think they are going to ask you this kind of questions. Who is father, brother, sister? No one will ask you. Okay, sir, I will go with Morton only. Okay, go with Morton only. No one is saying, but it's up to you. Finally, you pray to your favorite god and jump and put Morton. Because nowhere in standard textbook it has been given that W.T.G. Morton, but in one textbook of anesthesia it has given that John Snow, because that was given, that is a UK-based published textbook, so he said John Snow. So we'll go with the UK-based published textbook, which is very popular, so that is John Snow only. So please choose this option wisely, or else you can go with Morton also. I don't want to create any controversy, right? So this is about history of anesthesia. Then came our very famous Katappa. Who is our Katappa? He is August Bayer. What did he do? I'm just writing it as Katappa. Don't take it very seriously for your remembrance. My whole point is not to tell you the story. My whole point is to make you remember. If someone asks you, you should be able to tell. Or some MCQ comes, random MCQ comes. You should not feel that sir has not taught us. But you should not forget what is history. So why I call him Katappa? Why we call him as Katappa? He's the first person who has given first spinal anesthesia. You can correlate, right? So first spinal anesthesia was administered by August Bayer, not Beer. August. Bayer. You can remember like this also. First spinal anesthesia was administered by August Bayer. Then came the first muscle relaxant that is used. First muscle relaxant that is used, that is E-tubo-curare. E-tubo-curare. This was used by Harold Griffith. Griffith, you can just remember. So what he has done is he has observed that the tribal people of Africa, they were hunting the animals. And when they were hunting the animals, they were using the arrow poison. And he noticed a very peculiar thing. They called it as arrow poison, but it is not a poison. Why? Because if they have used a real poison, the whole meat what they have hunted, that has become inedible for eating. But what he has noticed was these tribal people of Africa, they are very, very smart. They used to extract a crude plant extraction. Chondrodendron, they used to extract the crude plant extraction. They used to dip the arrow and they used to hunt. Whenever the arrow struck that animal, the animal used to walk up to a certain distance. Slowly, all the muscles will get fatigued and it used to fall down onto the ground. The animal was alive. The meat was fresh. But the meat was not poison. They have not used the real poison, but it was called it as arrow poison. So he extracted from the crude form and he has used this D-tubo-curare as the first muscle relaxant. Then came the first local anesthetic that was used. First local anesthetic that was used was cocaine. Very famous cocaine by Carl Koller. You know what he has noticed? Carl Koller has noticed about the people who were chewing the leaves of cocaine. Erythroxylone cocoa. That's the trade name of the plant. So people used to chew the leaves. The cocaine used to have the euphoric effect. So and what they have noticed, what this Carl Koller has noticed is the people who were chewing these leaves, the tongue has become numb. Then they are not talking like normally. They are talking and they are biting their own tongue. So many days people thought that they are in a state of euphoria or they are in a state of hallucination. They are biting their own tongue. But what this Carl Koller has noticed is that the tongue has become numb. So he extracted the crude form, and very important, he has used it for ophthalmic. He is an ophthalmic surgeon, so he has used it for ophthalmic surgery. So this is how the history has evolved. See, as in one movie it has said, who is the first person to land on the moon? So everyone is interested in knowing who is the first person, what he has done. So these are the first discoveries of anesthesia and they went onto the wall of fame. I hope many of you students, you discover new things and you enter into this wall of fame. I couldn't do this, but you have a very good opportunity for doing this. So this is the historical aspects which were important previously. So you can go through it and you can remember this table. That would be easy for you. Okay. Welcome to this module of pre-anesthesia checkup. What I am going to tell you in this pre-anesthesia checkup, I'll tell you how to prepare a patient for surgery. As I said you in the beginning also, so this is a very important aspect for an entrance examination. So the title of the topic is pre-anesthesia checkup. In this we are covering how to prepare a patient for surgery. How to prepare a patient for surgery. This is a very important aspect for an intern who is preparing a patient. No one will expect you to do a surgery. Big surgeries also, it's a responsibility of an intern to prepare this patient. properly so that he will not have any problems. So let us begin with my story. Okay, why go for another story? I'll tell you my own story. As I said, I have not attended my anesthesia postings. I have not attended classes very seriously or sincerely. So what happened, when I passed out of my medical college, that was the first day of my internship posting. I still remember a very interesting day. On that day, what happened, I was very much excited. First day of my internship posting. Early morning, I got up nicely shaved, a formal pant, formal shirt, apron, stethoscope, knee hammer, torchlight, everything was there in my pocket. And my postings were surgical postings. So I went to the surgical department, and in the surgical department, immediately my senior has asked me to go and do the ward rounds. Immediately I went and did the ward rounds. So after that ward rounds, what happened? We used to see the OB. We used to clear up. There were around 300 patients per day in that hospital we used where I did my undergraduation. So 300 patients were there, and I was I was going through the OB patients. So in that department, we have an unwritten rule saying that we will keep some 10-15 case patients separately so that my professor sees that patients and he decides whom to be posted. So before the patient is posted for surgery, he would like to discuss with the case with the residents and interns on the day. So I had one patient, I thought he's a suitable candidate for surgery, inguinal hernia patient, a 40-year-old male gentleman with a swelling in the inguinal region. So I kept this patient aside. So before lunch, after the OP has finished, I shifted, I along with my residents, we went inside into a nice AC room. You can imagine, my professor was a very great man. He used to sit in a chair, AC room, comfortably. He was like this. Okay, what are the cases you got? So I said this is the case. So he said, do you want to present this case? Because I was a fresh intern. So yes, I said. So he started asking me the questions. He started asking me the questions about inguinal canal, boundaries of inguinal canal, what are the various approaches, what is the nerves that are present. Then I was parrot, just now I passed the theory, parrot I was answering, question, answer, question, answer, question, answer. The patient was sitting in front of me, the professor was sitting there, patient was sitting there, patient was in between me, and he was looking like this, tick, 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 question, answer. My professor was really impressed. He said yes, you prepare this patient for surgery, day after tomorrow is the patient posted, you will be my assistant. I was really excited. So immediately, in government hospital, if you leave the patient, he will run away. So I catch hold of that patient and I shifted the patient to the laboratory. I got all the basic investigations done and I went for canteen for a lunch break. So in the canteen, I was having all the lunch and all the things. While coming out of the canteen, I found out that this patient was also coming in the opposite direction. I was with my friends, colleagues. So when I was coming out, this patient saw me and he said, sir. I said, my colleagues were really surprised to see, sir, first day of internship posting, what you have done? I said, fine, common, yeah. So what happened, in the afternoon period, once everything was finished, I catch hold of the same patient and I went for a pre-anesthesia checkup. I went into the operation theater. For the first time, I went into the operation theater and I asked it, I asked the anesthesia resident, this is the patient I got. I don't know whether it was a, bad time to enter. He was obviously in a bad mood. Most of the anesthetists are in a bad mood. Then what? I said, sir, this patient is posted. Immediately, he started asking me the questions. So many questions he asked. Question, no answer. Question, no answer. Question, no answer. Because all these days, as as I said I know about boundaries of inguinal. I don't know how to prepare this patient. And he was asking me not very, he was not asking me something which is ridiculous. He was asking me questions which are very, very pertinent to the clinical situation. And I don't have any answer for him to tell. And the patient was sitting there. You can imagine. Question, no answer. Question, no answer. Question. Immediately he realized that he is the junior most doctor of the hospital. And he said, Dr. Saab, I will not go with you. So immediately I went out and I called up my resident. He asked me, so what is the situation? I said, hey, he got approval from anesthesia. No, I said, no. Then he came down, we worked up the patient, and finally we shifted the patient. Now I don't want you to land up in the same situation. So I will tell you how to prepare a patient for surgery. That's the whole point of, that's a very important area for your entrance examination also, right? So let us see how are we going. So let us first see what is the goal of pre-anesthesia checkup. We, in a polished way, if you want to say, we call it as pre-op evaluation. Pre-op evaluation also. We can keep it this heading also, pre-op evaluation also. That's not a big deal. So what is the goal of pre-anesthesia checkup? Many times we have a privilege, anesthetists have a privilege that whatever the cases that are scheduled, we will see on the first time. Unlike in your outpatient departments, where you see the patient for the first time, here, whenever a patient is scheduled for an elective surgery, I have a privilege that I will see him one day before. So that, I can make out the notes of the patient, what we are going through it. So what is the goal of pre-anesthesia checkup? Why? Because, many times we identify the problems for the first time in the pre-anesthesia checkup. In our country, we don't have, this medical records properly. Many times, I have diagnosed so many patients with hypertension first time just before getting an operated for an elective surgery. We don't get that health checkups very frequently. So this is very important pre-anesthesia checkup. So what is the goal of pre-anesthesia checkup? Is to make sure that the patient tolerates surgery, anesthesia, and anesthesia comfortably. Right? What is the second goal? To optimize the patient general condition. Before posting him for surgery. So there he might be having, as I said there are so many diseases, hypertension, diabetes, thyroid problem. These are first time detected in the pre-anesthesia checkup clinic only. It is the best time for the patient to know about his health. You can advise him. So we are not called as anesthetists here. We are called as pre-operative physicians or peri-operative physicians. Your physician, a medicine guy, he will be busy with his medicine OP, medicine wards, ICU. Surgery guy, he will be busy with surgery, cutting, suturing, right? But anesthetist is one guy, he acts like peri-operative physician or pre-operative physician, where he identifies the medical problem. He knows what are the implications of the medical problem, and he knows how to treat the medical problem so that the patient can safely tolerate anesthesia and surgery, right? So we act as a role of physician. So it's nothing, there is no new thing in pre-operative or pre-anesthesia checkup. It's a very simple, whatever you know as a physician, I also do the same thing. So what does a PSE include? So many times students think that PSE, you might have seen in your medical colleges, there are so many big charts are there. Here we have so many charts are there, but in a nutshell, if you ask me what is a PSE, what does a good PSE include? A good PSE, it includes complete history from the patient, complete history of the patient. It includes general examination. It includes systemic examination. Sir, this is same, sir, like what we have done in medicine. As I said you, this is same. History, general examination, systemic examination. Normally after systemic examination in medicine, what will you do? You will send for laboratory for diagnosis, you come to a differential diagnosis, you come to a diagnosis and you go for a treatment. Here in anesthesia, what we do is, we have one more examination that is called as airway examination. So we do like this. So history, what does the history include? So you all must be knowing from the second year, you are attending your clinical postings. In your clinical postings, you are taught how to take the history. The same history, whatever you are taught in your second year, whatever you are doing in third year, final year, intern, the same history I am also following. There is no change at all. So what does your complete history include? That includes the demographic details like name of the patient, age of the patient, sex, address. We all know what is the significance of name, age, sex, address, ID number, etc. I'll not go into the details because you are all masters of it. Then comes chief complaint of the patient. Chief complaint, in the patient own words I will take. What is the problem? Why he is going for surgery? Then you will talk about history of present illness. This is what you have been doing in your clinicals, right? History of present illness, history of past medical history or past medical history, history of past medical illness. Then you will ask about personal history. Then you will ask about family history. Then you will ask about personal history, family history, allergy history. Then we will ask about past surgical history. Suppose if the patient is a child, you will ask about immunization history. If the patient is a female, you will ask about the menstrual history. Right? The same thing. Whatever you are asking, the same headings I am keeping. My way of looking at the things are different. Many people think that pre-anesthesia is checkup which has been bought suddenly from the sky. No, it has not been bought. It is the same, like if you know how to take a patient out, how to look at a patient in medicine, surgery, the same things I am also looking. My way of looking at the things are different. Right? So what do you ask in general examination? You will note down the height of the patient, you note down the weight of the patient, you note down the pulse rate, you note down the blood pressure of the patient. Right? You will tell whether the patient is comfortably sitting, standing on the patient, etc. Right? In the same way, in systemic examination, what will you do? You will do the systemic examination of cardiovascular system, respiratory system, GIT, CNS, where you do inspection, palpation, percussion, and auscultation. Then we all know this, sir. Why are you writing and making us write? Yes, it's the same thing what you are doing. The only new thing what we are adding is airway examination. We are doing a separate module on airway examination. Okay, the rest of the things, if you know this, that means pre-anesthesia checkup is over. That's a so simple thing, sir. Why are we complicating? So I'll tell you what is the things that we, or what is my way of looking at the things as an anesthetist. So up to name, age, sex, address is over. Chief complaint is over. History of present illness, everything is same up to history of present illness. Then where is the difference starts? The difference starts in the history of past medical illness or past medical history. So normally in past medical history, what will you ask? Now what happens is in past medical history, if you are a medicine or if you are having medicine postings, you will ask about hypertension, diabetes, epilepsy, thyroid, etc. Now what I am going to do is I am going to deal with all these diseases individually. I am going to tell you what is the effect of these diseases on the surgery. I am going to tell you how to optimize these diseases before patient getting operated, and what are the complications or what are the things that you need to keep it in mind. That's the whole point of pre-anesthesia checkup. Shall we go into past medical history? So the rest of the things are same. So history taking is same. General examination is same. Systemic examination is same. Okay, anyway, as I said, I will talk about it later. So shall we go into the past medical history? Very good. So past medical history, so we have a scenario because it's a more of clinical oriented approach rather than using the word hypertension. We are putting you a scenario. What is the scenario? Hypertension. A patient is posted for an elective surgery. In the pre-anesthesia checkup, you have noticed that the patient blood pressure is around 180 by 130 millimeters of mercury. 180 by 130 millimeters of mercury. Can I schedule this patient for surgery? Can I post it for surgery? Can I post for surgery? So obviously, what is your answer? Obviously, your answer is no. Why? Why you are not posting it for surgery? So as I said you, I will tell you the concept behind why we are not posting this patient for surgery. I will tell you how to optimize this patient and what are the anesthesia considerations. On these headings, whatever might be the past medical history, on these headings we are going to understand the disease so that it will build a conceptual knowledge. You can answer multiple varied type of MCQs and you know how to prepare your patient for that. So you know how to, what are we doing practically also. Right? So let us see what we are going to understand in the history. So as I said you, 180 by 130 blood pressure of BP, and you know the concept why he is not scheduled for surgery. So what is the reason why he is not scheduled for surgery? You might be knowing, sir, I know the concept that reason is at this high blood pressure, the patient will bleed like hell. He will bleed during the surgical procedure, and that's the reason why we are not scheduling him for surgery. Yes, that's a very good reason, but the answer is not correct. Why? Sir, will bleed, sir. I also know, you also know. But what is the anesthetist point of view? Who is operating on you? Surgeon. Who is cutting your skin? Surgeon. Who will face the dilemma, or who will face this problem of bleeding? Surgeon. So who should be worried? Surgeon should be worried. Yes, obviously you are right. But why am I worried about the high blood pressure? What is the anesthetic perspective of it? Try to understand it. So what is the concept is, if a patient is having high blood pressure, most of my anesthetics, what is the concept? I'll write it like this so that you will understand. So hypertension concept. What is the concept? What we are trying to understand is, at this high blood pressure, as I said you, most of my anesthetics are depressant. Most of anesthetic drugs are depressants. Anesthetic drugs are depressants. So what do they do? So they decrease the blood pressure. Sir, that's a very wonderful thing, sir. Then why are we not using this patient? At 180 by 130, if I give any of my anesthetic, majority of my anesthetic drugs, immediately the blood pressure will fall down from 180 by 130 to 80 by 50. 80 by 50 mm of HCG. Is it okay? Is it okay? No, this is not at all okay. Why? Why? Because I will tell you a concept behind it. In your physiology, you might have understood, or you might have read about a term that is called as auto-regulation. What do you mean by auto-regulation? Auto-regulation means in your body there are three systems. One is your brain, the second one is your heart, the third one is your kidney. These three systems, they have CNS, CVS, renal. They have auto-regulation. What does it mean by auto-regulation? So the auto-regulation means whatever might be the blood pressure, the perfusion to the organ remains same within the physiological range. If there is a BP fluctuation also, the pressure, the perfusion to these vital organs will be maintained. So if I draw a graph, something like this, where there is the perfusion of organ, perfusion of an organ, any organ, it can be brain, it can be heart, or it can be a kidney, and the mean arterial pressure. The mean arterial pressure. If you draw the curve, then it will be something like this. It will be something like this. Within the physiological range, can you appreciate what I have told you in theory? Don't get panicked when you look at the graph. Theory, the concept is very simple. Within physiological range, the perfusion of the organ remains constant. The perfusion of the organ remains constant within physiological range. This is auto-regulation. Now what happens in a patient who is chronically hypertensive? What happens is, see here, in this patient, this curve, this has been moved something like this to your right. In chronic hypertensive patients, what happened is, in chronic hypertensive patients, this curve, auto-regulation curve, is set to a next level. That is, it has been moved to a right side. So what will happen is, here the auto-regulation, normal auto-regulation is 50 to 150. But in chronically hypertensive patient, the auto-regulation has moved somewhere between 110 to 200. Imagine, these are just arbitrary numbers so that you will understand. So in chronically hypertensive patient, this curve has been moved from 50 to 150 to 110 to 200 millimeters of mercury. So if the blood pressure rapidly falls down, for a patient who is having 120 by 80 to 80 by 50, it is okay. But a patient who is having 180 by 130 dropping down to 80 by 50 is very, very dangerous, because he will be on this part of the curve. The mean arterial pressure has dropped to such an extent, sudden reduction of the blood pressure, which will fall on this portion of the curve where the perfusion of the organ is low. Perfusion of vital organ is low. So that is the reason why I don't want the pressure. So that is the reason why in your medicine, whenever you see a highly elevated blood pressure, you will not immediately reduce it. You will reduce it gradually, so that this curve, what is shifted to your right, slowly moves to your left. Right? So that's the reason why we don't want any highly elevated blood pressure to drop down quickly, because once it drops down to the quickly, what will happen is, it will affect the perfusion. What will happen if it affects the perfusion? Immediately, the patient in the post-operative period, he might be having renal impairment, or he might be having CVA, or he might be having a coronary artery disease. Right? So that's the reason why we don't reduce the blood pressure from a very high level to a normal level very quickly. Gradually, we try to reduce it. So that is one of the very important reasons why we are not taking the patient at 180 by 130. Bleeding is your reason. But my reason, understand, I am mixing physiology with anesthesia. So if the blood pressure is highly elevated, auto-regulation is set to a next level. So when you reduce it drastically, it will cause to the hypoperfusion of vital organs. That is the word that has been given in the textbook. Hypoperfusion of vital organs. Why this hypoperfusion? This is the concept. Right? So now you understand the concept. Then comes what is the optimization? How do you optimize this patient? How do you optimize this patient? Now understood. As I said, you anesthesia is physiology plus pharmacology. How do you optimize? If you are a physician, if you have seen a patient who is hale and healthy walking into your OPD clinic with 180 by 130, immediately you will put him on anti-hypertensive medications, anti-hypertensive drugs. The same drugs what you are using to control the blood pressure, I am also using the same drugs. Why, sir? Because I am a perioperative physician. So what are the group of anti-hypertensive drugs? You know? You might be knowing it, right? There are beta blockers, there are calcium channel blockers, there are ACE inhibitors, there are ARBs, right? They are centrally acting antihypertensives, central sympatholytics. So many group of drugs are there. I am not going into the details of pharmacology, because your pharmacology faculty has covered all these drugs in detail. If I start telling you about all these drugs, it will be a class of pharmacology, right? So Physiology is regulating the pharmacoregulation. Pharmacology is knowing about the drugs. What is anesthetic consideration? So the anesthetic consideration is most very important. Will you continue antihypertensives till the day of surgery or not? Will you continue antihypertensives till on the day of surgery, or not? The answer is yes. All antihypertensives should be continued till the day of surgery. Except, very important, except which one? Except ACE inhibitors and ARBs. ACE inhibitors and ARBs. What is the example of ACE inhibitors? Yes, very good. ACE inhibitors examples are captopril, enalapril, lisinopril, etc. What is the example of ARBs? ACE means angiotensin converting enzyme inhibitors. ARBs, what are the examples of ARBs? That is telmisartan, losartan, etc. Right? Except these drugs, all antihypertensives should be continued till the day of surgery. Why? What is the reason? Very important. Once I had a patient, one of my relative had got a high blood pressure. It was around 170/100. He was having headache. He came to me. I checked the blood pressure. Immediately, I kept him on Enam 5 mg, that is enalapril 5 mg. So after 1 week, he came back again. I checked the blood pressure. It came down to 120/80. I said it's normal. In the next question, my relative asked me is, shall I stop these medications? What is your answer? I said no. You should not stop these medications. You should continue throughout your life. I asked immediately. The next question I asked him, why do you want to stop these medications? So what he said is, what is the side effects of ACE inhibitors? Yes, you are right. The very important side effect is coughing. So is there any significance under anesthesia? No. The patient will be knocked off. So I am not worried about coughing. Sir, there is one more important side effect, that is angioneurotic edema. I am not worried about angioneurotic edema because this is a rare complication. I am least concerned about it. But what is the problem? I asked my relative, what was your problem? Why do you want to stop this medication? Immediately he said, sir, everything is fine, sir. But when I get up from the bed, I feel dizzy for a moment. What is this? Yes, you are right. It is postural hypotension. So these ACE inhibitors and ARBs, they are the powerful controller of your blood pressures. So what happens is, under anesthetics, they can cause ACE inhibitors and ARBs, they can cause severe intractable hypotension. So better, if I know there is a hypotension, why I will go there? Right? So most of the times, if there is a chance that there is a problem, I will not put my leg there. So what is the answer solution is, if the patient can go into severe hypotension, intractable hypotension, then obviously what I will do is, I will stop ACE inhibitors or ARBs before surgery. Very simple, right? Now comes a very important clinical situation, right? So now you understood what is the concept. Now you understood how to optimize it. In the concept there is physiology, in the optimization there is pharmacology. Now understood anesthetic, pharmacology, right? Now you understood the anesthetic considerations. What is the clinical oriented scenario here? So the question that was asked in your entrance examination, look at the question. A patient is posted for cataract surgery. I am not rewriting all the question because it will take some time. A patient is posted for cataract surgery. He is on telmisartan 40 mg. He is taking telmisartan 40 mg daily. What is the correct statement? Telmisartan shall be continued or shall be stopped? So you might be thinking it should be stopped, but the answer is continued. Sir, just now you only said that you stop ACE inhibitors and ARBs. Why are we continuing again? So please look at this anesthetic. Anesthesia is purely a clinical branch. There are no fixed rules here. Please try to understand. Very important. Look at the surgery. That's the reason why anesthesia is kept in surgical allied branches. I am not looking at anesthesia alone. I am looking at the surgery. Understood? There is physiology, there is pharmacology, there is medicine combining with surgery. Right? So why continue? Because cataract is a minor surgery. So what is the exception? It is a minor surgery where I am not expecting that much amount of blood loss. If I am not expecting that much amount of blood loss, or if I am not expecting there is no fluid shift, then you can safely continue. So please write down there only. So anesthetic considerations, all antihypertensives should be continued except ACE inhibitors and ARBs. Already you have written. Depending on the surgery, depending on type of surgery. If the surgery is a minor surgery, so what is the definition of minor surgery? Where there is no much blood loss, no fluid shifts, then you can continue. Suppose if the same patient is scheduled for a Whipple's procedure, then it is obviously you need to stop it because it can cause intractable hypotension. Understood? How we looking at it? So this is one medical example, or in past medical history which I am looking. This is how I am looking at the subject. So concept, optimization, and anesthesia considerations. If you learn like this, your concepts will be, it will be fixed for you forever in your lifetime. You need not mug up the things. You just need to remember the important aspects, and you can answer whatever might be the clinical scenario that comes into your examination. Shall we move to the next next scenario? Yes. So what is the next scenario? A patient is posted for elective surgery. In pre-anesthesia checkup, in the lab investigations, you found out the sugars are around 450 milligrams per deciliter. So what is this condition? This is diabetes mellitus. Can I schedule this patient for surgery? Yes or no? Obviously, your answer is a very big no. Why it is no? I know you know the answer. So patient is having 450 milligrams. Immediately your mind will think that the patient will go into, the patient will have poor wound healing. Obviously, the poor wound healing will ask him to make him to stay in the hospital for a lengthier period. So that is the reason why we are not scheduling him for surgery. Very good, you are right. I am not saying you are wrong. But what is the anesthetic perspective? Who is cutting your skin? Surgeon. Who should be worried about healing? Surgeon. Then why I am worried at 450 milligrams per deciliter of sugars? Very, very important. Understand the concept again. What is the concept? So the concept is, see here, physiology. So what are the acute complications of elevated blood sugars or acute complications of diabetes? Acute complications of diabetes mellitus. I am writing it as DM. Immediately don't say acute complications of diabetes. Don't say diabetic retinopathy. Diabetic retinopathy comes after 20 years on an average. Minimum 10 years to 20 years it will take. This is not acute complication. This is chronic complication. Diabetic retinopathy, diabetic neuropathy, diabetic nephropathy. They are all chronic complications. I want acute complications of diabetes. Yes, the first acute complication of diabetes is diabetic ketoacidosis. DKA, very important in your medicine. Diabetic ketoacidosis. If the sugars are very high, the patient can go into diabetic ketoacidosis. Or the second acute complication is hyperglycemic coma. Hyperglycemic, hyperosmolar coma. Hyperosmolar coma. What is the third acute complication? Very, very important complication is hypoglycemia. Many students they forget it. Hypoglycemia. I am not going to tell you how to identify diabetic ketoacidosis. It will be covered in your medicine. How to diagnose diabetic ketoacidosis or what investigations, what is the management. You are all masters of it. I know that. Right? I am telling you about anesthetic perspective. Out of all these three complications, which are very dangerous under anesthesia. Very important. Hypoglycemia is very dangerous. Sir, hypoglycemia, how can it be dangerous, sir? If the patient is having hypoglycemia, immediately I will give him some sugar. I will give him some dextrose. The sugar levels are controlled. Yes, that is right, absolutely right. But it is very dangerous under anesthesia. Why? Because what are the signs and symptoms of hypoglycemia? Whenever you feel hypoglycemia, you will have lightheadedness, right? Lightheadedness. You will have tremors. You will have confusion. You will have palpitations. You will have tremors, you will have palpitations, you will have lightheadedness, confusion, etc. And immediately you go to your kitchen and put some sugar into your mouth. Very good. But all these signs, can you see lightheadedness under anesthesia? Can you see tremors under anesthesia? No, you cannot see. Can a patient tell that I am having confusion? No, you cannot see. Patient cannot tell. So the problem is the patient, all these signs and symptoms are masked. So the word that is used in textbook is signs and symptoms of hypoglycemia are masked under anesthesia, especially under general anesthesia. That is the reason why hypoglycemia is dangerous. It's not about the treatment. It's about identifying the problem. How do you identify hypoglycemia? Immediately, if the patient is unconscious, you check the sugar levels. But when the patient goes into this hypoglycemic state, we don't know. Surgery is for 6 hours. So every 5 minutes or 10 minutes, you will not go on puncturing the sugar levels. You are not going to check the sugar levels. It is like the situation of a boy or a girl in a medical college who cannot tell, who cannot express her love. At the same time, the opposite sex cannot understand. He cannot tell, he will not understand. Or he cannot tell, she will not understand. So in the same way, my patient cannot tell, I cannot understand. Because I don't know, I am not going to puncture his whole of the fingers to check the GRPS level. So hypoglycemia signs and symptoms are dangerous under general anesthesia because I have got only 3 minutes of time. Within 3 minutes, if I don't identify the problem, if I don't treat that, what will happen? Finally, he will go into a permanent neurological damage. So under anesthesia, hypoglycemia is very, very not identifying the problem. How do you identify hypoglycemia? Immediately, if the patient is unconscious, you check the especially under general anesthesia. That is the reason why hypoglycemia is dangerous. It's not about the treatment. It's about identifying the problem. How do you identify hypoglycemia? Immediately, if the patient is unconscious, you check the sugar levels. But when the patient goes into this hypoglycemic state, we don't know. Surgery is for 6 hours. So every 5 minutes or 10 minutes, you will not go on puncturing the sugar levels. You are not going to check the sugar levels. It is like the situation of a boy or a girl in a medical college who cannot tell, who cannot express her love. At the same time, the opposite sex cannot understand. He cannot tell, he will not understand. Or he cannot tell, she will not understand. So in the same way, my patient cannot tell, I cannot understand. Because I don't know, I am not going to puncture his whole of the fingers to check the GRPS level. So hypoglycemia signs and symptoms are dangerous under general anesthesia because I have got only 3 minutes of time. Within 3 minutes, if I don't identify the problem, if I don't treat that, what will happen? finally he will go into a permanent neurological damage. So under anesthesia, hypoglycemia is very, very dangerous. So I am worried not about wound healing, but I am worried about this concept that the patient can go into this hypoglycemia during surgery period or when the patient is unconscious. And within 3 minutes, if I don't identify, he will go into permanent neurological damage. So you understood the concept. Now what is the optimization? The optimization is very, very simple. Pharmacology. How do you control the sugar levels? You are all masters of pharmacology. What is that? So you might use oral hypoglycemic agents. Wonderful oral hypoglycemic agent, metformin, bigonide, sulfonylureas, pioglitazones, whatnot. You are like parrot telling me all the things. I can know that. And there is something called as insulins. Again, you all know about insulins. This was introduced by Batting and Best. A very important historical event was there, right? Fine, I'll not go into the details. Insulins are again classified into long-acting, short-acting, intermediate-acting, ultra-short-acting. We all know that, right? So all these insulins, I can get down the sugar levels from 450 milligrams per deciliter to normal. But I am not interested in your concept. I am interested in your anesthesia consideration. Very, very important anesthesia consideration. Will you continue OHGAs and insulins perioperatively? What is your answer? Yes or no? Yes or no? The answer is no. Why? As I said you, the common side effect of oral hypoglycemic agents and insulins is hypoglycemia. And under anesthesia, they are very, very dangerous. So what I do is very, very important. All oral hypoglycemic agents should be skipped. Should be stopped. We'll write it stopped only. Should be stopped on the day of surgery. There is one exception, or there is one important oral hypoglycemic agent, that is your SGLT2 inhibitors. They are very, very dangerous. Why? Because they can cause normoglycemic ketoacidosis or euglycemic SGLT2 inhibitor. They can cause euglycemic ketoacidosis. So what we do is SGLT2 inhibitors we will stop 24 hours prior to surgery. Very, very important. Right? So this previously when I was doing post-graduation, we used to say all oral hypoglycemic agents should be stopped. In the previous versions of Marrow also I told all oral hypoglycemic agents should be stopped. But in the recent version there is a slight change here. Understand? All oral hypoglycemic should be skipped on the day of surgery. SGLT2 inhibitors should be stopped 24 hours prior surgery because there are chances of euglycemic ketoacidosis. What about insulins, sir? So insulins again, long-acting insulins, all rest of the insulins you can stop. But long-acting insulins in type 1 diabetic, reduce the dose by 1/3. Whereas in type 2 diabetics, long-acting insulin, reduce the dose by half. So the whole point is actually there are, as I said you, this is a purely clinical branch. I am not interested in the numbers. I am looking at the sequence of the events. You know, 1/3 or half. My whole goal is not about the numbers. If a patient is getting some 20 units, I will not reduce it to 8 or 6 units if he is getting long-acting insulin. Right? So what is my goal is, my goal in diabetes mellitus is to maintain the sugar level between 120 to 200 milligrams per deciliter. That is my goal. It should not go less than 120. It should not go more than 200 milligrams. Why, sir? If it goes less than 120, just now I told you. Like, you know, medical college situation, you cannot tell, he cannot understand. Fine. And if it goes more than 200 milligrams, he might go into diabetic ketoacidosis, hyperglycemic hyperosmolar coma. I don't want that one also. So I am adjusting adjusting the drugs in such a way that if the sugar levels are fluctuating, my goal is to maintain between 120 to 200 milligram. Sir, but intraoperatively you have stopped some medications. So if the sugar levels are increased, what will we do? So please write down, if sugars are increased or blood sugars are increased intraoperatively, what I will do is we will use short acting insulins. We will use short acting insulins to maintain between 120 to 200 milligrams. Why, sir? Why only short acting, sir? Why not ultra short acting? Why not long acting? I'll tell you the reason. The short acting insulins, the onset will start within 10 minutes. The onset approximately it will start between 10 minutes. The peak action will come within 30 minutes. So what I do, if a patient is in general anesthesia and he is a diabetic patient, what I will do is I will check the glucose levels every 30 minutes. That is easy for me. Rather than checking every minute, I will check the glucose levels because I am using a short acting insulin. The duration of action will be around 30 to 45 minutes, not exactly, but every 30 minutes I can check the sugar levels and I can come to a conclusion that the patient is maintaining these levels or not. Understood the concept? So how beautifully we are managing the case of diabetes mellitus. I'm worried about the problems. I know how to control the problems. I know what are the goals of making the sugar under control. Next comes the third medical problem. In the past history, that what you ask commonly is epilepsy, right? So in epilepsy, can we schedule a patient, this kind of patient, can you schedule a patient who is throwing actively seizures? So suppose today morning at 9 o'clock a patient is scheduled for surgery, early morning at 4 o'clock a patient is having a seizure. Can you schedule that patient for surgery? Obviously, immediate or first onset of seizure, whatever it can be, before an elective surgery, obviously you need to reschedule the patient and you need to reschedule the case. You need to identify what is the problem and you need to take necessary actions. Okay, so not to be posted. Right? So obviously everyone, even surgeon will not be comfortable if the patient is throwing seizures today morning and at 9 o'clock an elective surgery is there. He will not be comfortable. He will ask what is the reason for the seizure, because this might affect adversely in the post-operative period. Suppose if a patient is a known case of seizure disorder, he is taking medications regularly. Then can we post him for surgery, or what is the important things we need to consider? So coming back to the physiology. So what is the concept? So a patient is having seizures. So what is the problem with the seizure? Understand the problem with seizure. So seizures, how many of you think seizures are dangerous to your body? So suppose if a patient is having one episode of seizure, do you think that it's dangerous, that's going to kill a patient? No, obviously seizures are not so dangerous. You might have observed in your city, especially in front of, that alcohol shops. Early morning you can see, or if you are going to a shopping mall, you can see many patients are wearing, in foreign countries, they wear a band. Suddenly they fall onto the ground, they have the episode, and suddenly they get up and they clean their dress and they go away. They are not worried. You might have seen many patients, especially in my city, in early morning in front of alcohol shop, you find so many people are waiting. Suddenly they get this seizure episode and some person will come and he will take one keychain and keep it in the hand of the patient. Fine, everything gets sorted off. Then why are we using this medication? I'll tell you the concept. So seizures, one episode of seizure is not a dangerous thing. Why? Seizure, what do you mean by seizure or epilepsy? It's a sudden activation of brain cells, sudden activation of neurons in the brain, which will be presented to you in the form of generalized tonic-clonic seizures, or we call it as GTCS. generalized tonic-clonic seizures. Sudden activation, hyper-excitable neurons are there. There can be any reason for this hyper-excitability. It can be, the reason can be anything. It can be a congenital lesion. It can be a iatrogenic. It can be a traumatic. It can be idiopathic. It can be a neoplastic. Anything. It can be any reason that it is causing hyperexcitement to your brain and it is presenting to you as GTCS episode. But these are dangerous? If you ask me, they are not dangerous. Why I said they are not dangerous? The reason being is, suppose that's a law of nature. Whenever anything is excited, it should come down to normal. So one episode of seizure, it will always come down to normal. Then why are we using the medication? Understand, very important, during a seizure episode, a patient can have, very important. Have you observed a seizure patient? He'll be like having so this kind of sound you can get. Why this sound is getting in a patient? Because of the airway obstruction. The moment you get a GTCS episode, you fall down onto the ground and immediately your tongue is going backward and it is causing airway obstruction. And whenever there is an airway obstruction during a seizure episode, it can lead to hypoxia. It can lead to hypercarbia. It can also lead to acidosis. Now these three are very important problem to me. Whenever there is hypoxia, whenever there is hypercarbia, whenever there is acidosis, what will happen is one seizure episode, abnormal excitation of the brain cells while coming down, whenever there is hypoxia, hypercarbia and acidosis, there will be triggering of second episode. There will be triggering of third episode, fourth episode, fifth episode. So one seizure episode, whenever you have hypoxia, hypercarbia, acidosis, one triggering agent, because of these triggering agents, there will be multiple episodes of seizure and he might be landing up in status epilepticus. He might be having one episode, second episode, third episode, continuous seizure, and this is a real problem to me. This will cause permanent neurological injury. Understood? So seizures, one episode is not a problem. The only thing is you have to take care that the patient should not have hypoxia, hypercarbia or acidosis. Suppose you are walking on a road. You are walking on a road, a patient in front of you or a person in front of you suddenly fall down onto the ground. He might be having one episode, second episode, third episode, continuous seizure, and this is a real problem to me. This will cause permanent neurological injury. Understood? So seizures, one episode is not a problem. The only thing is you have to take care that the patient should not have hypoxia, hypercarbia or acidosis. Suppose you are walking on a road. You are walking on a road, a patient in front of you or a person in front of you suddenly fall down onto the ground and he is having this episode of seizure. What will you do? Immediately take a keychain and keep it in the hand of the patient. Immediately what you need to do is you turn the patient into left lateral position. You just clear the area because all the people will be surrounding. You just make it everything clear, or you turn the patient into left lateral position, because the whole problem, I'm not worried about seizure episode. I can control the seizure episode, but I'm worried about this hypoxia. So what I have to do is what is the reason for hypoxia? Airway obstruction. So what I can do is, in order to prevent the tongue fall back, don't keep your fingers into the oral cavity and try to sweep the tongue. I have seen a patient where one of the bystander, what he tried to do is he tried to keep something in a patient who is actively throwing the seizure and he has bitten all of his fingers. So don't keep anything when a patient is throwing seizure. Don't keep anything when a patient is into the oral cavity, when a patient is throwing the seizure. So try to keep the patient in left lateral position, because this will break the vicious cycle of hypoxia. Right? Sir, you can say me, sir, I am a 40 kg girl, the patient is 120 kg person. How to turn him to left lateral position? So one thing what you can do is, or what I will do is, I will use my two fingers and I will do this jaw thrust maneuver. I will try to pull the jaw of the patient. I'll try to pull the jaw of the patient using my two fingers. I will try to pull the jaw of the patient. So what will happen? If I pull the jaw of the patient, immediately there will be straightening, or there will be increased tensile strength of your muscles, and the tongue which is falling back, it will be become straight. So the first step you need to do is, before administration of medication, is to prevent hypoxia. Is whenever you are all alone outside the hospital, immediately do a jaw thrust maneuver so that you can straighten the airway and you can break the vicious cycle. Very important. A simple step, rather than searching for a keychain, keeping it in the hands of the patient, doing all the nonsense stuff. Try to do this jaw thrust maneuver. This will, before that only, call for a help. You need to give some medication, right? Suppose if you are in hospital and if the patient is getting seizure episode, immediately on a first note, what we will do is, we will give intravenous. If there is an IV line, immediately we try to secure the IV line of the patient, and we try to give intravenous short-acting benzodiazepine. Short-acting benzodiazepine. What is the short-acting in benzodiazepine? You know, I also know one thing, that is midazolam. Wonderfully, I will give 1 mg of midazolam, but very important is, you should understand that midazolam immediately it reduces the seizure because it has got anti-epileptic properties. But you have to be careful because you should monitor the patient. You cannot leave the patient because midazolam has got a very bad property. It causes respiratory depression also. So, if the patient is having seizure episode, first, on a first shot, don't think of any other drug. You are in casualty, immediately think of benzodiazepine, short acting. Don't think of diazepam. Diazepam is gone long back, because many students, they tell me benzodiazepine, immediately diazepam comes like a flash. Diazepam is gone long back when I was doing PG, right? So long back in 2007 only it was gone. So don't think of diazepam. Short acting, quick acting, or immediate effect, it will be shown by midazolam. But unfortunate thing is, midazolam is not long lasting. So after giving, once seizure episode is controlled, we will give around what is called as phenytoin sodium. Phenytoin sodium. How much is the dose of phenytoin sodium? Do you remember in your medicine? Yes, it is 15 to 20 milligrams per kilogram diluted in 100 ml normal saline, given over 45 minutes. Slowly you have to give phenytoin sodium. Or nowadays we are having better drugs like levetiracetam, Levipil, right? You can give around 20 mg per kg of Levipil and it will take care of the seizure episode. So for immediate control, we use benzodiazepine, short-acting benzodiazepine, right? Understood the concept of seizure? Seizure is an abnormal activation of the brain. My whole goal before administering of the drugs is to break the vicious cycle of hypoxia, hypercarbia and acidosis, right? Now coming back to our concept. So if a patient is a well-controlled seizure episode, this is the concept. So how are we optimizing the patient? We are using some anti-epileptic drugs. Anti-epileptic drugs. So you know there are various kinds of anti-epileptic drugs. I am not going into the details of anti-epileptic drugs. So my only concern, this is pharmacology. Optimization is pharmacology, right? So what is my anesthetic consideration? Do we continue anti-epileptic medications till the day of surgery or not? The answer is, all anti-epileptic drugs should be continued. Very, very important. Should be continued till the day of surgery. Till the day of surgery. Very important MCQ. Sir, why we are continuing? Because, you know, all my anesthetics are depressants, especially, you know, but there are some anesthetics which are stimulants also. What are those examples are? Please note down these examples. When we are talking about drugs, we will be knowing it better. Write down here so that when you are revising, it will come into your brain. So there are some drugs like enflurane. Nowadays we are not using it. Methohexital. Actually, they stimulate your brain. So these are contraindicated. They stimulate brain and they are contraindicated in patients with history of seizures. So nowadays we are not using it, not worried, but it is an important MCQ. When a patient is having a seizure episode, you should not use the drugs like methotrexate or enflurane. So these can precipitate seizure episode. Very, very important MCQ. But one more important thing in a perioperative role, as a physician, as I said you, if a patient is on anti-epileptic drug, what precautions you should take? You said already you are continuing these drugs till the day of surgery. But when a patient comes to me in pre-anesthesia checkup and he says that, sir, I am using these medications, I will always order along with your CBC, that is your complete blood picture, complete blood count, and serum electrolytes, I will order LFT, liver function test. So why complete blood picture? Suppose if there is an infection, I can identify, because any kind of infection, brain infection, meningitis, etc., that will be aggravating. In serum electrolytes are very important investigation to rule out, if they should be normal, because any abnormal electrolyte conditions like hyponatremia, etc., they can also precipitate seizure. So I will rule out these investigation. Why I am ordering liver function test? How is it connected with anti-epileptic drugs? Remember, all anti-epileptic drugs are enzyme inducers. So they can stimulate your cytochrome P450. That is the reason why I am ordering liver function test along with serum electrolytes and CBP, etc. I will be looking. I am interested. Suppose if the patient is having so many medications, I want to look at the liver function test of the patient in the pre-operative period. Because one of the strongest risk factor for post-operative mortality is acute fulminant liver failure, and this has been showed that the patients there are certain group of patients who are risk factors to develop into acute fulminant liver failure. One of the group of patients are who are on anti-epileptic drugs, because all these anti-epileptic drugs are enzyme inducers acting on your cytochrome P450. So understood how we are optimizing a patient. So immediate seizure episode, don't take it for surgery. A well-controlled seizure patient, then these are the things you need to keep it in mind. If a patient is having seizure, how to control it. If he is on anti-epileptic medication, this is how you need to optimize the patient general condition. Understood? Shall we move to the next disorder? Yes. The next disorder is thyroid disorder. If a patient is found to be having a TSH value of 25, what does it mean? In pre-operative investigation, patient is having a TSH value of 25. So what does it mean? She is hypothyroid patient. How to optimize this? What is the problem? What is the problem with hypothyroidism? So let us try to understand it. Again, what is the concept? That is physiology. If the patient is hypothyroid, what is my problem? My problem is, surgeon can say, sir, surgery is somewhere down in the abdomen. Why are you worried? My problem is, thyroid is one important hormone which maintains the basal metabolic rate, BMR, basal metabolic rate. In hypothyroid patients, what will happen? The BMR is also reduced. If the BMR is reduced, the basal metabolic rate is reduced, in general anesthesia, I am giving so many drugs like induction agent, muscle relaxants, opioids, etc., etc. Do you think metabolism of all these drugs will be faster or delayed? Obviously, when there is a decreased BMR, metabolism of the drugs are decreased, leading to delay in recovery. So this is the problem. That's the reason why if a patient is having hypothyroidism in pre-operative period, what we do is we try to control the hypothyroid. So how do we control? So how do we optimize? What is pharmacology? Optimization. So you give some thyroid supplements, that is your thyroxine supplementation. So we know what is the effects of thyroxine supplementation, etc. What is the anesthetic consideration? Do you like to continue hypothyroid medications or stop? So obviously continue thyroid supplementations. Wonderful. Hypothyroidism, You all know the fact that this is how we concept optimization and anesthesia consideration. Now see the second kind of patient. A patient is having a thyroid TSH value of 0.01. What is the normal range of TSH? Immediately don't check your lab values. It should be remain in your mind. So the normal value of TSH is 0.5 to 5. Right? So if it is 0.01, what does it mean? That means that the patient is a hyperthyroid patient. The patient is having hyperthyroidism. So what is the concept now? So in hyperthyroidism situation, what is the problem? Hyperthyroidism, shall we continue the drugs or not? Directly jumping into anesthesia question. Shall we continue? Sir, hypo stop, hypo continue, hyper stop. Don't think like that. I'll tell you the reason. So one of the main important function of thyroid hormone is maintaining the BMR. But in hyperthyroid patients, the signs and symptoms. What are the signs and symptoms of hyperthyroidism? So on a grossly, if you look at a patient, the patient will have ophthalmic features, that is exophthalmic features, right? The patient will have primary hyperthyroidic features, that is CNS is involved, where your patient will present with tremors. I am not worried about tremors also, but I am worried about serious problems, serious effects of hyperthyroidism, where it will cause palpitations. So the real question is, what do you mean by palpitations? Abnormal awareness of one's own heartbeat, right? So the most common palpitation that I can encounter is atrial arrhythmias, especially when a patient is scheduled for thyroid surgery, and the patient is not prepared well for thyroid surgery, and the surgeon touches the thyroid gland. Immediately the thyroid hormones are released into your circulation, and the patient rhythm may go into atrial arrhythmias or atrial fibrillation. Right? Understood? That is my problem. That is the real concept behind why are we optimizing the hyperthyroidism. So how to optimize it? So what is pharmacology? The pharmacology, you are all masters of pharmacology. What are the anti-thyroid drugs you know? I know propylthiouracil, carbimazole, methimazole, Lugol's iodine, radioactive iodine therapy, etc. So many drugs are we use, right? I'll not go into the details of pharmacology. What is the anesthesia consideration? Would you like to continue or stop? Continue or stop? So answer is very, very clear. Continue anti-thyroid medications. Till the day of surgery. Continue anti-thyroid medications till the day of surgery. Very, very important for your entrance examination. Many students, they think hypothyroid, continue, hyperthyroid, stop. No, don't. This is the concept behind it. Now, one more important anesthetic point I would like to add is, if a patient is having hypothyroid, obviously you might like to control, but it is an emergency surgery. So what can we do? You cannot say control thyroid and post him later. By the time you get control, the patient will be dead. So what we do in case of emergency surgery in hypothyroid patient, we use ketamine as induction agent. Understood? Why ketamine is stimulant? We'll talk about ketamine in pharmacology section. So if there is an emergency surgery and if they want to give general anesthesia, I will not use any drugs. You prefer ketamine. Severe hypothyroid patient, I prefer ketamine because that is one way I can get some stimulus to your body. Right? One more thing. If the patient is having an emergency surgery of amputation, imagine severe hypothyroid patient, amputation. There is a gangrene of lower limb and we not to do amputation. So what we do is we prefer regional anesthesia. Why? Regional anesthesia, the patient will be awake. So I will try to optimize in the post-operative period. So severe hyperthyroidism, and if there is a possibility, I will go for regional anesthesia. If there is a possibility, I will try to avoid general anesthesia as much as possible. And if required, if general anesthesia is mandatory, I will go for ketamine. Suppose if there is a hyperthyroid patient, and again it is an emergency surgery, Again, it is an emergency surgery. What I will do is, I will make sure that I keep all the drugs like esmolol, which control beta blockers, which control the heart rate, in my hand, and I prefer to use thiopentone sodium. Why? You have to refer to the pharmacology section where I have told you why we are using thiopentone sodium, because thiopentone sodium has got anti-thyroid properties. And again, in hyperthyroid also, emergency surgery is there. Wherever that is, I don't want to go the patient into general anesthesia. If it is an emergency surgery, then I want to, wherever possibility is there, I will go for regional anesthesia. If I am not able to get the regional anesthesia, suppose it is a laparotomy, I cannot do it under regional anesthesia alone. So I will prefer for something like thiopentone sodium as an induction agent. Understood? So this is how I am looking at the things in case of thyroid disorders. Right. Coming to the next disorder, psychiatry problem. Which of the following psychiatry medication should be stopped prior elective surgery? Now, this was the same question that was somewhere asked in UPSC examination. Few years back, it has been asked. So instead of giving the names, they have given the trade names or the drug names. Right? So I'll tell you one interesting incident that happened to me only, because anesthesia, it's a dry branch. If I don't tell you my experiences, you will never understand. Right? So what is the incident that happened to me? I was working for a hospital few years back when I freshly passed out. So what happened one fine day, I was doing a pre-anesthetic checkup for a patient. In pre-anesthesia checkup, my patient was, he was posted for hernia surgery. He was around 7 feet height tall. Very well-built muscular personality. But when I am talking to him in pre-anesthesia checkup, he was not having eye-to-eye contact with me. He was looking somewhere here, he was looking somewhere down. He was not answering to me properly. I asked repeatedly, do you have any problem? Do you have any problem? He said, nothing. So I said like, okay, fine. So I gave fitness. I have given spinal anesthesia next day. The patient was posted for surgery. Everything went on smooth. And on the evening, I went back to my home. Next day morning, when I came back to my hospital, I just saw into the post-operative period, all my nursing staff were there waiting for me in the post-operative ward. When I entered into the post-operative ward, I found that my patient was, he was sleeping. He was deeply sedated. I don't know the reason. Immediately, I asked my nursing superintendent, what has happened? What has happened to my patient? Yesterday, he was hale and healthy. Suddenly, why he is so deep? Why all of you have gathered? Immediately, my nursing superintendent, she got pissed off with me and she said, why are you looking at here? Look at this. I saw the yesterday night duties. Like, the day before that night duty, there were 2 young sisters were there, nursing staff were there in my hospital. They are like thin, lean girls, justly passed out their nursing course, and they were doing night duties in the hospital. They were crying, weeping. I went there and I asked, what happened, ma? Why are you crying? Immediately, they increased their tone of crying and they said, sir, yesterday night, your patient, this patient, he was at 12 o'clock, he got up, he was running behind these 2 nursing staff, holding an IV stand to beat them. Imagine yourself, 7 feet height person, and my nursing staff are like, 40-45 kg girls, small girls, right? And they are crying, how horrifying it would be, and it is in a post-operative ward where you don't have that much amount of access. So immediately I went out and I asked the patient attender, sir, why did your patient behave like this? The patient attender was smilingly saying, sir, he was having small psychiatric problems, sir, schizophrenia. I was like, you idiot, you have to be told, you have to be telling me first. So, patients don't tell up. In our country, we have this stigma of psychiatric problem. So, they didn't told me. Unfortunately, I didn't realize. I was having some suspicion, but every patient, I cannot tell him a psychiatric patient, right? So, what I did was, I have not ordered him anything. So, he skipped his medications on the day of surgery, and on the night, this attack precipitated. Now, you answer me a question. Do you wish to continue antipsychotic medications or not? Yes. Very good. All antipsychotic medications, write down all antipsychotic medications should be continued. Should be, you will never forget. Once you listen to this story, you will never forget. Should be continued till the day of surgery. Till the day of surgery. This is not MCQ, but I told you story, but this is not MCQ. What is the MCQ? Except, very, very important, that is MAO inhibitors. MAO inhibitors, especially the older MAO inhibitors. older MAO inhibitors. Why? Because older MAO inhibitors, they interact with synthetic opioids. I use lot of opioids to control the pain in the post-operative period. Synthetic opioids like meperidine, synthetic opioids like meperidine, that is pithidine. The trade name is pithidine. So what they do is they cause a cheese-like reaction where they will be increasing in heart rate, increase in blood pressure, surge of catecholamines. There will be release of catecholamines. Sudden outburst release of catecholamines if I use older MAO inhibitors plus synthetic opioids. So previously they used to advocate that older MAO inhibitors, they should be stopped 2 to 3 weeks prior surgery. 2 to 3 weeks prior surgery. They used to give a rule that if a patient is on antipsychotic medication, older MAO inhibitors should be stopped 2 to 3 weeks prior surgery. But nowadays we are not using, many psychiatrists are also, they are not using this MAO inhibitors. Nowadays we got a better drugs, that is SSRIs. Fluoxetine, paroxetine, etc., right? So, they are using one more group of antipsychotic agents, that is tricyclic antidepressants. We have some novel antipsychotic agents, phenothiazines, buprenorphines, etc., right? So, rest of all antipsychotic agents can be continued. So whenever a patient is on antipsychotic medications, except for older MAO inhibitors, the rest of antipsychotic medication should be continued. If you stopped, you understood what is my story. Right? Now there is one more twist here. What is the twist? So there is one more group of drugs, that is lithium. Where we use lithium? Lithium is used in your psychiatry in the treatment of bipolar disorder. Again, this is not very commonly used, but it is a very important drug. Lithium is used in the treatment of bipolar disorder. Again, one more antipsychotic medication, which is not an antipsychotic medication actually. One more drug, that is magnesium. Where do we use magnesium? Magnesium as magnesium sulfate. Yes, in eclampsia. Pre-eclampsia, eclampsia we use. Why I mixed these two drugs? Lithium and magnesium, they interact with muscle relaxants and prolong the duration of muscle relaxant. Right. Now, if lithium and magnesium are interacting with my muscle relaxants, what should I do? So, shall I stop it? Immediately the answer, you might get an answer as no, but the answer is magnesium should be continued. Never ever think that you are going to stop magnesium sulfate in a patient with pre-eclampsia. Immediately your obstetrician comes and squeezes off your life like this. They will be shouting and screaming at you because the patient will be throwing seizures and 2 lives are at stake, mother and child. So magnesium should be continued. It should not be stopped. I will modify my anesthesia technique, but I will not change. I will not stop magnesium. What about lithium, sir? Poor psychiatrist, sir. Can we stop it? Now, what happened is previously they used to say lithium should be stopped 24 hours. Previously they used to say 24 to 48 hours you need to stop. But what happened very recently, 3 or 4 years back, what happened? A patient is having bipolar disorder, and one of the poor anesthetist, he said, not in our country, but in other country it has happened. So poor anesthetist, what he has said, as per guidelines, it should be stopped 2 days prior, and he has stopped lithium. And just before the day of surgery, the patient went to the 5th floor and he committed suicide. Immediately they gave a new guideline saying that lithium, try to continue. Immediately all anesthetists started shouting, sir, it will interact with my muscle relaxants. Now what happened is we got newer muscle relaxants like which are short acting, like atracurium, cis-atracurium, mivacurium, which are short acting. short acting. So when a patient is on these kind of drugs, like if a patient is on lithium, I need to change the anesthesia plan, because surgeon will be waiting in the operation theater in the pre-anesthesia checkup. Anesthetist has stopped lithium, the patient has committed suicide, then surgeon will be looking at you like this, right? So this is all going to be a a whole messy thing. So if a patient is on lithium, first assess the patient clinically. Previously they used to say guideline, but nowadays first assess the patient clinically. If the patient is on, if you feel that the patient or the psychiatrist feels that the lithium should be continued, immediately what you have to do is you have to change your anesthesia plan and use some drugs which do not interact, or they are short acting drugs. So atracurium, cisatracurium and mevacuram. Why are these short acting drugs? Why we are using it? Once you refer the pharmacology section, you will understand. So there is no hard and fast rule. The textbook says it very clearly that assess the patient clinically. Previously, I only used to take 24 to 48 hours. In edition 3, edition 4, I used to say 24 to 48 hours. But nowadays, it has been changed. So don't stop lithium unless you get a proper psychiatry advice. If he feels like okay, then you can stop it. Otherwise, you change your anesthesia plan. But nowadays, it has been changed. So don't